So we can add over here that HO or MO should be there, that heterotropic ossification or the myositis ossification, which would be held at the level of the the hip joint or at any at the knee, because if it happens, then it should the patient is not able to, if he is able to sit, he is not able to stand in a straight position, or if he is likewise one of my patient having the injury of L1 L2, a female, but she is not able to sit at 90-degree of angle. She's always sitting in nearly 35 to 45 degree of angle, because he is not able to get the hip joint at 90 degree. The range of the hip joint was not there. So what I need, what I feel that in known medical condition, if we put heterotropic ossification or the myositis ossification, it will be a great help for the therapist as well as for the person who is taking the assessment, so that it would be easy to tell to those patients that will you able to use this arise wheelchair properly or not, so this is my suggestion, that's why I asked. And the second one, in wheelchair mobility, because when we teach the wheelchair mobility, we teach the advanced and the basic level of wheelchair courses, right? So this you just put at the wheelie. So because wheelie comes under basic wheelchair also, as well as for the advanced level. So can we clarify this also, that whether it's a basic wheelchair mobility or the advanced level of wheelchair mobility?
Mr. Vikram, the first clarification, it was point on. So you were saying that we need to add a range of motion restrictions like myositis ossificans or heterotropic. So we have a
Right.
section on measuring the range of motion. So when we have these conditions, obviously the
Uh-huh.
range of motion is going to be affected. Okay.
Okay.
So we'll be capturing that information over there in the range of motion section, which is yet to follow. So we do have thought about it, and
Okay.
someone with a HO at the hip or the knee or MO will have range of motion restriction, and they will be filtered out. So we'll
Okay.
take a subjective decision. So we have a section for measuring the range of motion. What you
Uh-huh.
said is already been included, just that the name is not here in the complication.
Okay.
Okay, that is number one. Second thing is wheelchair mobility. So the purpose of adding this section, so even if we add different components of wheelchair mobility, we are not going to get any benefit out of it in the prescription process. So the only
Uh-huh.
reason this wheelie skill is put here is based on the wheelie skill, we can set
Uh-huh.
up the center of gravity during the fitting
Okay.
process. So
Okay.
otherwise, the other components will only be a matter of training after the wheelchair has been given. So we had only this advanced. So this wheel, it differs. So the level one of wheelie or the poor grade of wheelie
Mm-hmm.
is it will fall under basic. So a moderate will fall under moderate wheelchair skills, and the wheelie doing a wheelie good amount of wheelie skill, doing a rotation with 360 degrees with the wheels up will be advanced skill. So we
Okay.
look at only wheelie as a skill, and based on that input, we tend to change the center of gravity. That's the purpose it is being presented.
Okay. Okay. Okay.
So
Sounds good.
if we
Yeah.
capture extra information like what is the exact current wheelchair skills, all the wheelchair skills like transfers, everything, we help
Mm-hmm.
only
Mm-hmm.
in training. That obviously is anyway going. The therapist is going to teach in the training guide.
Okay. Yeah.
Have I answered your question?
Yeah.
Okay, thank you.
Sir, I have one question.
Yes, sir.
Sir, suppose the person is having a kyphosis or scoliosis, can we refer these features?
Yes, sir. The person again it depends on the severity essentially. If it is not too bad in sense like the person, it is not affecting too much of alignment in the sense excessive weight distribution on one side to the other side. Then in mild to moderate cases, the person will become eligible, sir.
Okay.
Samson,
So,
would you like to add on something?
yeah, I'd like to add on to Karthik. So here a lot of clinical judgment will be needed from the person who's assessing. Scoliosis can be functional or structural, and kyphosis also can be fixed at sometimes, like in terms of heterotropic ossification of the hips. So we'll have to apply a clinical justification, clinical reasoning to determine whether this person will be able to withstand the frictional forces and withstand the balance loss when they are doing the sitting to stand movement. So based on our judgment, we can classify the person into two, whether the person is eligible to take the standing wheelchair or not, or the person is not eligible, or whether the scoliosis can be corrected with some partial support devices. So based on that, we can engage in some further modification to the wheelchair, or we can just say that the person is not fit for using the standing wheelchair by itself.
So suppose if we give some trunk supports, okay,
Mhm.
so minor adjustments, we can make some trunk supports for them.
Mhm.
Can we recommend for this?
Yeah. So the ultimate key is with modification, will the problem be sorted out or not? For example, if there's a balance issue when the person is standing, it might result in a very bad harm to the user. So if the balance issue is going to be sorted, and if the frictional forces are going to be sorted out because of excessive pressure on one side because of scoliosis, or if the person's spine is kind of very protruding, and if it's not going to be rubbing on the backrest and causing a frictional ulcer over there, then if a modification or training or some deformity correction is going to solve all these problems, then we can go ahead and use it.
Okay.
So when things don't seem very appropriate, even if it is can be corrected, or even if it can be addressed with modifications, we'll have to enter them into a category that they're not temporarily eligible to use it. We have to work on the person to do some changes, or work on the wheelchair, and then only give it the wheelchair. So because all the modification, I assume, will take some time, it has to be customized to some extent, and we don't have any ready-made solutions as of now. So it will take some time.
Okay.
So we'll have to keep that person on hold. So a lot of clinical reasoning and clinical decision making will be involved here.
Okay.
Is a standard 18 by 18 size.
So I think this will be addressed by a specification sheet from Phoenix. So we have 5 different sizes from 15 inches of width to 18 inches of width. Sorry, 4 different sizes of seat width, and we have 3 different seat depths for each width.
Okay.
So
So we
it
have
is
that
seat
one.
depth is adjustable, and seat width we have different sizes, 4 sizes.
Exactly.
So based
Thanks.
on how, so based on the assessment, based on whether the person had a skin injury or lack of sensation, we can determine how much extra clearance also we want. We can choose the seat size based on that.
Thank you. Thank you.
Thank you for your question.
Clear.
There is a question about exclusion criteria. Okay, essentially exclusion criteria would mean people who are not eligible for using a right standing wheelchair. The most obvious ones would be osteoporosis, because then the bones are very weak, and one of the reasons leading to osteoporosis would be lack of adequate standing experience. And so these people would end up with osteoporosis, and they become non-eligible for that. And then there are other issues like orthostatic hypotension. There could be, and other things are all related to judgmental, which means you will look at if the person had a fracture, if the person had if has an heterotopic ossification, if the person has a contracture or deformity, if the person has scoliosis and those kind of problems. So everything will have a role in the exclusion. I mean, it be based on the person's ability, we'll do that. The other thing that we'll also look at is the height and weight of the person. Samson, do you want to explain more on that?
Yes. So what we'll do is actually we'll go through the form and mark out all the exclusion criteria from the beginning. So as Karthik said, first thing we'll look at is whether the person is osteoporotic or not. So based on all scientific evidences, a person with osteoporosis has a higher risk of fracture. It doesn't mean that a person will definitely have a fracture, but the person is actually having a higher risk of fracture. And that will be determined, we will find out. So we cannot ask everybody to go and take a bone scan or the DEXA scan and come to us. It's quite expensive as well. So we do some filters initially. So first we look at the age. If somebody is higher than 55 years of age for Indian population, then we can suspect that this person can have an osteoporosis. And then what we look at is the date of onset. If somebody had a spinal cord injury 5 years back, and then next we look at the standing status. And if that person is not standing regularly, like the person has not stood up for the past 6 months in a regular basis and with the proper amount of loading to the lower limbs, then we can suspect that person can have osteoporosis, because all those are fluid. And so based on these two, we ask the person. So only if these are negative, the person is aged, if the person has a long onset of injury or a long history of the disability, and if the person has not been standing regularly, it raises a red flag. So then we ask the person to take a bone scan and come. So that will, if it shows that there's osteoporosis, then that person can be excluded. If it's osteopenia, probably we can use a clinical decision and take a call on that. So the two regions where we recommend taking the bone scan is, so checking the osteoporosis, is the neck of femur and the shaft of femur. So those are the two areas which we feel it's risky. The people can argue that the neck of femur only gets affected by torsional forces, but we do have chances of torsional forces in the standing wheelchair. It's unlike a standing frame where the person is locked in multiple directions. The person has relatively more range of or degree of freedom in the standing wheelchair. So with osteoporosis in the neck of femur, it's highly risky. So we have included that. So when we look at initial input, and then when we find out that the person has osteoporosis, the neck of femur or the shaft of femur, then we can exclude this person. So that is the first one. Second thing is we look at different deformities or different contractures and deformities. So say contracture of the TA or equinus deformity, and then we'll come to knee flexion deformity, and then we'll come to hip flexion deformity, or hip flexion, or say it can be a heterotopic ossification at hip or at the knee. Or some range restriction in the spine where the person is not able to sit erect or stand erect. If the person has a hunch, there is no support to hold the person in place. Or if the person has a dislocation of one of the hips, and it's surprising to see that it's quite common in persons with spinal cord injury to have a dislocation along with the actual spine injury. If there's dislocation of the hip, and that, then it falls an exclusion criteria. So based on how severe the deformities are and how severe the contractures are, we'll have to exclude them from permanently using the array standing wheelchair. If it is a milder version of a contracture, if it can be stretched or if it can be operated and made correct, making the range of motion possible to neutral in many different places, then we can take into like a temporary hold list. So we can work on them until they reach the adequate range of motion required for the arrays. And then third thing is acute severe pain. So if the pain is going to be aggravated while standing, while the movement of standing, or while movement, different activities involved in the standing wheelchair, like using the levers, or while standing, if the pain is going to be aggravated, then it's going to be risky. So we'll have to find out the reason for the pain, or we'll have to find out the reason for the pain, see whether it can be corrected, and then exclude. Because if it hurts the person every time he stands, if it's not going to be, if it's nociceptic, and if it's has a history behind it, which is going to be which is not going to be comfortable for the person, it's going to result in some injury, then we'll have to exclude the person based on the pain. So then we can exclude based on different things. So say the orthostatic hypotension or peripheral vascular disease. If somebody has a deep vein thrombosis, definitely no. So then it becomes risky. So, and if somebody has a fracture in the past 3 months, and if it is not healed, and if the bone is not strong over there, and no, that person will be excluded. And then we will come to active pressure ulcer. That is one important area where we'll have to exclude. So if the person has active pressure ulcers in these 4 areas, say the ischium, we can follow the table for which is mentioned for sensation. So if the person has active pressure ulcers in both the ischiums, or either of the ischiums, or either of the greater trochanters, or the sacrum, or the patella. We have added patella here because there's a part of the wheelchair which holds the knees in place. If a person has active pressure ulcers in these areas, then definitely no, because it's going to increase the pressure ulcer, and it will lead to a lot of damage to the person. So we'll have to exclude that person. If there's edema which is going to like be risky, so because if the edema is because of some deep thrombosis, then we'll have to exclude. Otherwise, if it's dependent and that should be fine. And then we'll have to exclude the person based on the range of motion intersection. If the person doesn't get neutral at the ankle or neutral at the ankle in both ways, flexion as well as rotation, inversion, aversion, and if the person doesn't get at least 90 degrees of knee flexion, 100 degrees of hip flexion, flexible vertebral column, then we'll have to exclude them based on the range of motion. And then we can exclude a person based on the muscle tone. And if the muscle tone on the upper limb, if it is more, then we can make the person use with help of a caregiver and use a clinical judgment whether this person will be able to use a standing wheelchair or not. Upper limb muscle tone may not be directly used for exclusion, but we'll have to apply some clinical knowledge over there. But lower limb, definitely, if it's more than 2, then it's going to cause restriction while the person is standing. We can exclude that group of people. And yeah, discussed about tightness contracture deformity earlier. And if the limb length discrepancy is more than 2 inches, or more than 2 inches, then I don't think it can be corrected, because the knee and the hip will not be aligned properly for the parts of the wheelchair which is going to hold them in place. So if the LLD is more than 2 inches combined with the femur and tibia, then we'll have to exclude that person. And when coming to the mechanical assessment tool, here again a lot of clinical judgment will be involved when there's a large amount of force required to correct this, and if we don't have a good postural support device to complement it or to substitute for that movement, or if the amount of the direction of force cannot be complemented by the postural support device, and if it's going to cause problems like friction, or it's going to cause problems like a change in posture which is significant while standing, we'll have to exclude them. So you can make a note of all that in the problems identified and then come to a conclusion. So we will in fact provide a list of what components, what will be the exclusion criteria, what will be the criteria for postponing the selection, or what components can be directly, if positive, we can directly proceed for the selection. So this will be covered under fitting. So we will so once the wheelchair is available, we will take you through. The plan is to take everyone through how this affects the fitting of the wheelchair and the reason behind it, because I believe everything cannot be transferred, all the knowledge cannot be transferred to people in a single form or a single guide. We'll have to learn it by practice. So that's the reason we have not covered it in this presentation.
And since there is a wheelchair assist, there is a weight range as well, which is like 40 kgs to 110 kgs, and that is the weight range that is suitable for use of wheelchair. So people less than 40 or people more than 110 kg will not be eligible for using the wheelchair.
Yes, sorry, I forgot on important things. So the wheelchair has limitations in weight as well as height. So the wheelchair is intended for the person who is 4 foot 10 inches tall to 5 foot 10 inches tall. A person who is taller than 5 foot 10 inches will not be able to fit in the wheelchair. It was taken, the Indian Anthropometric data for the average population has been taken and designed for this unit. Probably in the future, it can have a new version for taller people as well. Just like we covered a big chunk of population in the bell curve, and the height who can fit in the wheelchair comfortably is, this is I'm telling based on adjustments. So from 4 foot 10 inches to 5 foot 10 inches. If anybody falls below 4 foot 10 inches or above 5 foot 10 inches, then they can be excluded directly.
This is Raju. It's very nice form, developed very detailed and very good information we could get from here. What am I understanding overall? The form is mainly to understand, to exclude. It is absolutely, I mean, they are not suitable. There are red flags. There are conditions, maybe they're yellow, that we can observe and monitor and we can progress to next level. And there is a green flags where the people can directly, we can just go ahead. That's what I can understand here. I think this can be, as after saying Samsung or the clinical reasoning behind it, like each assessment and which area we can take it as a red, which area we can take it yellow, which we can take as a green flags. So that's what we can understand. Can we? I mean, I'm looking at the larger people going to use this form as a now 10 members or 15 members. We understand this and we can reasoning it out and understand. But this form may be going to the not only India, worldwide. It may go wherever the wheelchair is going. This all can be summarized in one sheet or one paper. Can have like a screening out. Simple way screening out. If someone is having so and so features, it is a red flag. We are not going for anything else. Okay, or maybe the assessing most of the therapists or the person who is doing that, they know how to use the gonimeter and understand the contracture, or someone is at risk of osteoporosis, then we may ask them to go for the density test. I think before going to the next level of that examination, there can be, we can have a think about a screening sheet which has a red or a yellow or green flags, each condition maybe, or which area of that risk factors. Then I think most of them, the examination time when we go, then we can, when whoever is a green person or whoever yellow flag person, only we can think about detail assessment. But what I understand, like each area we are going little depth, and we end of the, after finishing 7 pages of assessment sheet, then we may think, okay, no, this person may not require a chair. But I feel that we are spending a lot of time, then ultimately we're ending up with the which is contraindication to a wheelchair. I think that way can we, I'm just looking at the dividing the information, so that whether to spend time in going for assessment and detailed measurement before going to the examination. That's what I'm just looking at my idea. But otherwise, the information what is given here, very detailed it is, and we cannot miss out anything out of, assessing a wheelchair for who want a standing wheelchair. That's what I can see.
Thank you, Mr. Raju. You are actually point on that. So we can indeed have a table which will tell us the red, yellow, and green based on the initial assessment. So as you said, we also had a similar thought. Once everything is green, then only we'll move on to. So example, if somebody is osteoporotic, then we not proceed further into the assessment. So we can have a guiding sheet. So we didn't want to have many forms, so we can have a guiding sheet, as we say, to note down the responses.
Yeah.
So we will experiment in different ways. Probably we'll get in touch with you regarding that. What you have given is a very valuable suggestion, and that makes life easier for people who are assessing as well.
Yes, I thought also with practical experience, what we get here, like many of the wheelchair users refer to our rehabilitation centers by considering that themselves. They understand that this person required a so and so wheelchair. I can understand, like by the time 50% they decide, they may require a wheelchair first, and what kind of wheelchair also. Maybe some other NGO person or some other therapist may be referring to us. Many therapy centers may not have these rehabilitation setups, but they, as a therapist, they may think this person requires so and so category of wheelchair. With their experience or with their understanding what kind of wheelchair, the lifestyle, they may refer here. I think can a screening form also can help them to understand this person not require this wheelchair. Yes, this person require a wheelchair, something like this. I think a screening form also may helpful in the, as you mentioned that, but practically I think it's useful if it's come out with that kind of information.
Yes, you're absolutely right. So we will work on that.
My last question is that maneuvering is possible during standing?
No.
No.
So a person can only, a person can move from place A to place B while sitting in the wheelchair, and after the person moves to place B, and then they can lock the wheelchairs and stand.
What is the level of lock? Where is the lock?
Lock is this wheel, what do you call wheel locks, or the brakes, which are found in traditional wheelchairs. That is actually dependent on the user to lock it. There is no control, but when standing, the person cannot reach the rear wheels to propel by themselves, whereas an assistant can do that. But we don't recommend that. It will fall under some precautionary measure. So we'll caution the person not to do it, because if there's a small defect in the floor, or if the person goes to edge of a ramp or stair, then there can be a mishap. So we will not recommend that even while standing.
I have seen a video that the patient Is standing in so many steps, slowly, slowly pushing the pushing kind of things, and he's standing. And while he completely stand up, there is a lock or something kind there that he can lock it that position, or he has to hold the push rim to.
No, no, no. So after complete standing, the mechanism itself kind of locks the position. The person will not fall back. Is that what you're trying to ask?
Yes.
The
Yes,
person will not fall back. The mechanism is built in a way that after the terminal standing is achieved, the person will stay in that position unless the person intentionally uses his or her own muscle power to pull the wheelchair back. Some 5 degree of pulling, some sorry, 5 degree of pulling the mechanism back will allow the person to come back into sitting. So we have
so
a
geometrical locking is there.
yeah,
Okay.
and the standing is assisted by a compressed spring, so that one takes care of the person not falling back. Even when the person comes up to standing step by step, the weight has to be taken into account and the spring tension has to be adjusted according to the person, so that the person, when they stand up in a few increments, they will not fall back to the previous position.
What's the terminal angle? At 90 degree or it's 70 or 80?
80.
80.
80
So
degrees.
so when you look at these are two. So when you look at the alignment of all the joints, so all the joints will become to zero. The ankle, the knee, and the hip, they will all be in a straight line from the head. But
Okay.
the person as a whole will be at 80 degrees to the ground.
80 degree. Okay.
This is to enable the use of gravity to make the person stay in the wheelchair. Otherwise, if it's vertical, the person might have a tendency to fall for it.
Sounds good. Yeah. Okay. Thank you.
Hello, sir. I'm Dinesh here.
Yes, sir.
Is it mandatory to take all the tests? Because in case, say, like we have to assess the scoliosis or lordosis, but some of the patient might be bedridden. So it will not be possible because they would have not been in a sitting position, or they will be in the lying position for some time. So how it will be possible to complete all the tests, one? And secondly, there are some assessments which need a physical examination, like the sensation or the mechanical assessments. When we are over the telephonic or online, how we are going to achieve those assessments?
So you have two questions. One is a person who is bedridden. Is it necessary to do everything when the person is not having a good physical capacity? Is that what you mean?
Yes, yes.
Yeah. So based on that, based on how long the person has been bedridden, we can immediately go for the bone density test and probably exclude that person. If the person passes that, as Mr. Samaraju had suggested, we can have different levels of screening. The first level, obviously, we can think that person is lying down in the bed, not doing any physical activity for the past 1 year. We can do a bone scan and then tell the person is not suitable in the beginning itself. If that is not positive, and then we can go ahead doing other tests. So like if they don't have any range of motion restrictions or any other conditions like orthostatic hypotension, which is also a possibility while the person is bedridden, then we can definitely give the wheelchair. It will need a physical test. At cases where the person is not available, it will depend on the skill of the person to guide another therapist near the home of the person to remotely do the assessment, or sometimes we can use a caregiver also to do assessment, at least to find the bare minimum information which we need. It depends on how the person is skilled in a tele-rehabilitation or tele-assessment thing. It's not very easy to do in this kind of a mode, but we have actually done them.
Okay, okay, sir. Yeah.
We can have a training session for it.
Sure. Thank you.
So coming to Mr. Riaz's question, so acceptable standing posture, any checklist or guideline? Yes, we don't have a checklist, but the standing, we can actually make one checklist for that.
I want to ask one thing that we are not giving any pelvic belt, so that at the level of pelvic we are giving the belt at the chest, we are supporting the knee, but we are not give support to the at the pelvic area. So how the quadri patient, the person who is having the cervical cord injury, so is it possible for him to use this standing wheelchair if the person is having C7 or good C5, C6 level of injury and don't having the finger movement, but a good wrist movement was there, so that he to take that this wheelchair in a standing by pushing it at the standing level. So because there is no pelvic region where, so did you ever try it on the quadri patient for the cervical cord injury? Or it's a high level chair for high level para and low level para?
We have tried this for different levels of spinal cord injury. For the person without good hand grip, if that is what you mean by quadriplegia or quadriplegia, without a good hand grip, which is required to make them come up to standing, we would recommend the caregiver doing this action. So it will
Okay.
be difficult for the person to stand up, or the worst case, the person wants to sit up if there's a autonomic dyslexia or something. So it will be very risky to the life. So in all cases, if somebody doesn't have good hand function or the cognitive skills to come down to sitting, then we would recommend the caregiver to operate it whenever it is being operated to standing position.
There are persons who are having cervical cord injury. They don't have fingers movement, right? But they good wrist movement. They had good the forearm. They had good the biceps and the triceps. They are able to make themselves in upright position by 80 degree. Okay, but there is no trunk control. So because what I have seen in this video, that you are giving support at the thoracic level, near the xiphisternum and at the knee level, but there is no belt at the level of pelvic or at the level of waist. So for the quadri patient, so it is not mandatory for for the patient the higher level of injury to stabilize the pelvic area also, or it would be fine for you guys.
So it may not be required in most of the cases because the gravity and the seat angle takes care of it while standing or while sitting. So
Okay.
if we mean the pelvic stability, whether the person comes to a slouch or whether the person goes in obliquity position, so that will be taken care of that based on the mechanical assessment tool. That's the whole reason why we do the mechanical assessment test.
Uh-huh.
So based on that information, we might opt to add some postural support devices like
Okay.
pelvic belt or some modification to the cushion like an ischial wall to prevent uh, the posterior pelvic tilt. So there might be some modification required to maintain the posture. And for mild cases, most of the work, the gravity will do the job.
My one last question was there,
Yes,
that
sir.
nose which you put it, the nose of the wheelchair, the caster wheel, which is that much a little bit from the longer, it's forward of the wheelchair. So so see, like the person who are doing the job, right? I'm talking the person who is rehabilitated and doing the job is going to the office every time for 8 or 9 hours in a day. So is this wheelchair is uh, or is accessible with all the areas like the lift areas or the desk areas or something like that, or you guys are planning to modify in later stage or after a period of time so that the nose of the wheelchair it goes a little bit shorter and the the center of the gravity of the wheelchair comes a little bit in a compact size for the standing wheelchair. So because lots of my patients are asking about this, sir, agar if the nose is very long, then how can we take this wheelchair to the office? So standing is good that we are able to stand, but is it possible because in the office the spaces are not that much accessible? They make the accessible according to our basic wheelchair or something like that, or the active wheelchair. So if this wheelchair, the nose of this wheelchair is long, then how come it is possible that we can manage in the office? So are you planning anywhere to make it a little bit shorter in future aspect, or you are going with this only? So this is a question which is no, it's out of the league. I'm just because my patients are concerned. That's why I'm asking.
Absolutely correct. So I understand your concern. So this wheelchair has been designed in this particular way with a single caster wheel and an extended caster wheel to provide stability. So during the design, so the primary audience was people living in uneven rural terrains where
Okay.
rehabilitation services are not very affordable. People don't get to stand daily. They need 2-3 people to. Whereas in the city or urban areas, it's kind of easier. So it was meant to the cost. If you see the cost of the wheelchair as well as the weight of the wheelchair, 35 kgs. It may not be a very easy thing to transport into the car and take it to the office. But the primary audience was targeted at people living in rural terrains where stability is important, cost is important, and compactness may not be important. So that's how it was designed for. So as you said, it is not going to be possible for anyone to make this full-time the only wheelchair. It just makes it easier to stand compared to a using a K-force or using a standing frame or other modes of standing. Reduces the number of us. This is totally designed to replace standing action and not designed to replace a compact, maneuverable, user-propelled wheelchair. So definitely in indoors, in places where there's very less space for maneuvering, it is going to be difficult to use it. Depending on, again, how the user has to use it, we can suggest them to get this and use it in a particular way. So in future, maybe we can have a compact design, but as of now, this is the only offer.
Sounds good. Yeah. Thank you. Thank you.
So there's a question on chat box from Mr. Riaz Hussain. It's available to sale and service. Someone from Phoenix can clear it.
Yes, we do. We do have this.
We have a warranty of 1 year only on the frame, and yeah, that comes under the service part.
So Mr. Samaraj is given a suggestion. We have suggestion on assessment sheet to make it a simpler format, reduce the number of sheets. Sir, we will connect with you personally and have a detailed call on how to incorporate the suggestions. We will get back to you.
Sir, actually, usually in the seat depth, whatever body measurement we get, what our practice is, we usually minus 30 mm to 60 mm.
Yes.
Are you doing same thing here?
It's written there. It's written in column H. So we are reducing 25 mm here. So because it differs in the other wheelchair where the knee hanger angle is lesser. So here the knee hanger angle is more. So the feet are placed very forward in the other standing wheelchair. So we will have more gap between the cushion and the popliteal fossa. So we can reduce only 25 mm. So usually it will be somewhere between 25 mm to 50 mm. So 30 mm is the standard for regular wheelchairs. Here 25 mm should be fine. And again, end of the day, it should be verified by checkout. So we should place 2 fingers between the popliteal fossa and the cushion. That will determine it. Okay, right point, sir. You raised it. So can I ask Mr. Karthik to sit on the wheelchair so that we can show what clearance we are talking about? So the measurement will be taken till there, and we'll have to reduce. Only if you reduce, we can see that gap which Mr. Raju is showing over there. So if that gap is not there, then the person will not be able to sit erect like how we are sitting now. So there will be a lot of posterior pelvic tilt, and the person will have a very slouched posture, and the person there will be some kind of injury. There can be some kind of injury in the knee space, and the person's pressure point will shift a lot to the tailbone area. So this gap is very essential for the seat depth, and what we'll have to take the lowest limb length, lowest thigh length, and reduce 25 millimeters from that, with or without the orthosis or prosthesis.
What I understand, if there is a discrepancy in the leg height,
yes,
you're saying the adjustment need to be done under the cushion.
We'll have to fix the height according to the lowermost measurement, and the higher leg will be having some gap.
Yeah.
Okay. So that gap can be filled with some pads below the cushion. So between the seat, between the plywood and the cushion.
Okay. Our practice, what we do, maybe standing, maybe you're thinking that way, but our practice, what we do, we do adjustment in the footrest plate, or the build up the footrest plate.
I mean, yes, that is there. Correct. Yeah, on the shorter foot, that is there. That's correct. But here, because standing is going to be a bit complicated. If we raise, if the overall limb length, if the thigh is not matched for this LLD, the person will be standing tilted to one side because the person is standing.
But when you, what I think, if you raise anything under the thigh, is it going to any disturbance in the pelvic? Can be a pelvic rotated, or the elevation may happen one side. If you scoliosis may encouraged if you do something like that. That's what we practice here.
Pelvis, yeah, pelvis may not rotate here, and the cushion, no, in the back it has some pelvic support pads in the rear portion of the cushion that will actually hold the pelvis in neutral when the person is standing.
Okay.
So there will be rarely. So what you say will happen when the LLD is in multiple places. It can be in the thigh and it can be in the leg. That can be quite common or quite rare based on what the amount of people you see. When there are both, then it becomes complicated. When it is only the leg or when it's only the thigh, it's easier to compensate. If it's only the thigh, then we'll have to pad the front of the knee block and introduce a layer below the foot, as you said, no. So if that's the thigh length discrepancy, then we'll have to introduce a layer below the foot, but not in terms of leg length discrepancy. So this we are trying to optimize the pressure. If you get any suggestions after the webinar also, if you get any pressing questions or if you have any suggestions to make improve this program or the guide or the resources, please email to Phoenix Medical Systems. So from the clinical team, Amrita can be the point of contact. Probably Amrita, can you post your email ID on the chat box? So if people have some pressing questions, they can reach out to the clinical team. And Nishanti, you can give the email address of Phoenix, Arise at Phoenix. So they can reach out to Phoenix for Arise related clarification. Thank you all for attending today's session. It has been a pleasure to talk to all of you, and a lot of interesting doubts and very essential things have been discussed. A lot of suggestions have been received from your side. So we will keep in touch. Thank you very much.